Well, welcome everyone. I'm Dave Bahner. I'm from the Department of Emergency Medicine, Ohio State. I'm a professor of emergency medicine. I want to talk to you today about ultrasound in medical education milestones, when, where, and how. The first start, what is a milestone and what should they be in UME, GME, and CME? And I think when you're talking about ultrasound in medical education, it's not just medical students, it's a lifelong learning process. And so we're trying to demarcate excellence with ultrasound over this period of time. And just to give some of the terms we use it a lot, UME is undergraduate medical education. That's really regulated by the AAMC, and then the LCME, the Liaison Committee for Medical Education, it's sort of their regulatory body. The GME, graduate medical education, by the ACGME. MOC, maintenance of certification, is something that the ABMS is trying to do as far as their practitioners. So what you're seeing is this trajectory of students turning into residents and turning into attendings, and so they learn different skills. Concepts such as an EPA, an Entrustable professional activity, is a unit of professional work, and it's something from the AAMC, while the NAS is the next accreditation system. It was founded in 2013 by the ACGME to focus on outcomes rather than educational process. So the longest time it's what stage of training you're in, and that determines what you're able to do. And they're trying to go more outcomes or competency based versus time or temporal based. So competence in medicine, this is from a New England Journal of Medicine, talks about the habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, etc. And basically these three domains of attitude, knowledge, and skill is what describes competence. And so different individuals are trying to look at what's competence in medical education. And so this looking at a group of educators using a modified Delphi technique to try to do a series of questionnaires using an EM rotation, and looking at ACGME residency requirements and their competency domains, the AAMC Entrustable professional activities, and coming up with what they think is the best practice for what's a competent medical student in emergency medicine. This also happened in internal medicine and other specialties. Again, that bridge between medical school and residency, that UME to GME. And then out of academic medicine last year, a group saying that there needs to be better communication between ABMS, where they're monitoring all their physicians as far as their practice patterns, and giving feedback to residencies at the GME level. So again, you're seeing these overlaps, and can we try to coordinate what's going on in other areas and coordinate that with ultrasound. Most of us are familiar with the ACGME, the 6 domains of competence: medical knowledge, patient care, professionalism, communication, interpersonal skills, practice-based learning, systems-based practice. And there's many ways that we can try to assess these competencies through written exams, assessments, direct observation, clinical simulations, portfolios. And these same competencies can be looked at the residency level. And so this paper was talking about looking at the new milestones and comparing that to their older system, the Dreyfus method, a rotation-based assessment of residency. And what they found was that interns were scored lower on the milestones, while seniors were scored higher. And so milestones allowed a bit more of a spread and try to differentiate along these different competencies. So milestones are here to stay, and they're being used. So some of you may ask, why milestones? And I think it can be able to track the progress of trainees, guide curricular development, suggest specific assessment strategies, assist remediation for those users that don't have those various skills, and help for a national standardization and evaluation. Whenever we're going to talk about curricular development, we're going to talk about this later this afternoon also, there are steps to design a curricula. And when you look at these steps, these 6 steps that David Kern described for medical education, you could look at ultrasound and put these in and see that these steps need to be addressed. So what's the problem with ultrasound in medical education? And I think a lot of it's operator dependent. It really depends on the person who is behind the probe. And so that general needs assessment is at the UME level what's needed, at the GME level what's needed, and at the MOC or the attending level what is needed. You can then target that needs assessment for targeted learners. So at Med 1, What does a medical student at the end of anatomy need to know? Med 2, after their introduction to clinical medicine. Med 3 during the rotations before they graduate. What are the needs, and can you develop milestones to try to assess these? And then at residency, at an intern level, at graduating resident, and then at the attending level, not only first year out, but 5 years out, 10 years out. What are those milestones, and how can you try to assess those? Getting the goals and the specific measurable objectives for each of these cohorts is a key part to any curricula. And then the various educational strategies, and these usually fall into 3 realms. Asynchronous online learning, there's a wealth of content out there. Synchronous, face-to-face and hands-on sessions, or in the clinical practice, in rounds on rotations of learning this skill. The implementation of that curricula, and then giving this evaluation and feedback. What we see from all of these is that they interface with each other, and they're all components of when you're trying to design a curricula. When we think of who can use ultrasound, all the specialties are using it. Are they all using it at your shop versus another institution? And it's really the penetrance or the ultrasound footprint is different. But if we put a little slide out to the side here and said, do they have it in UME, GME, and MOC, as do they have milestones in these various areas, they're starting to develop those, but that's one of the challenges. If you look at emergency medicine, we use that pretty extensively. We do have a milestone for ultrasound. I don't believe that there's milestones at the GME level for these other specialties. Could there be? And is there going to be in the future? And I think that's what's going to be needed. This is something I started this kind of 30,000-foot view looking at ultrasound educational competency hierarchical outcome, is that we have learners, and that on the x-axis is normally what we look at as far as competence, as far as temporally based. And we know that this competence exists, that there's novices out there, basic learners, intermediate, and advanced. But it's really the z-axis of how much time you put into ultrasound, and you're going to get more training, become more proficient. And so the way I've thought of this when I've put in our program is at the student level is a kind of getting that basic understanding of ultrasound, then at the resident, intermediate, and then at the fellowship or attending level, advanced. These numbers have some historical reference, but they're not current. They're some numbers that have been bandied about as far as ultrasound training. But as you probably all realize, it's not based on just pure numbers, and I think that that's why the milestones are looking at other areas. We've presented this at the World Congress, this what we call the CRAE scale, the competency ranking assessment, and really trying to take those basic skills of knowing the echogenicities and learning things in medical school that they can build the foundation for your time in residency, and as you go on with more exams and more targeted objectives, that you can go up into the expert level. And this all goes back to what Miller's pyramid, talking about competency, is that knows how, shows how, and does. And I think that milestones mirror this competency. And Dr. Clayman references this learning pyramid of how we retain information. And Aristotle said teaching is the highest form of understanding. At the highest level here is when you can teach others. So I think having systems in place where students and learners at different levels can then teach others is key to any competency. So when you're out there asking, how do we measure and communicate competency and performance with others? So if you're running a medical student clerkship, how do you say that that student is going to be competent in ultrasound? Or if you're a resident director of ultrasound, is that resident able to go and apply for privileges? And what is that endpoint in these milestones? And I think a lot of it is what we're trying to do is define a new field. It's not ultrasonography, it's really ultrasonology. We're trying to train clinicians that are able to acquire images, interpret images, and make decisions at the bedside. So with that endpoint, you can look at milestones, let's say at the anatomy level, and have some medical student milestones at year 1. That then can dovetail into a curricula that allows them on their journey toward being a clinician to then perform clinical skills on the back end. So, for example, as they're learning head and neck ultrasound, they may have some milestones in anatomy, but then that gives them some experience. So when they're going to be doing central lines in their 3rd year, and then when they're going to be physicians that have to place those central lines as a resident, and then attendings. And so I think we really need to rethink this process as a lifelong learning, and there's various steps. When you look at the specialty of emergency medicine, they've delineated the milestones, that there's 23 various milestones for all of emergency medicine. Number 12 of these milestones is dedicated to ultrasound. It's the only one I know of that in residency is dedicated to ultrasound, and this is the milestone framework. And what it really does is say at the beginning of residency at an intern level that they're a level 1 is where they should start. And for ultrasound, describes the indications for emergency ultrasound. What the goal is as they go through residency that they develop these skills, and that by the time they're graduating residency, a level 4 is what a graduating resident should be able to do. And then a level 5 is what a practicing attending should be able to do. So level 2 is can they perform an EFAST? So during residency they learn that skill. Level 3, they correctly interpret acquired images and do multiple different types of exams. Level 4 is they get a total of 150 clinical exams. And level 5, these were made by individuals that weren't ultrasound trained, or just educators. They put all the things that made experts, so things such as TE and bowel ultrasound. Some of us have not really thought that that was the best level 5, and one of the things that we've adapted is we say that level 5 is can you document, save your images, and bill for ultrasound. So knowing that back-end skill set that you're going to need to do. So this is for emergency medicine, these milestones, but they all follow the same framework where you start off as an intern and that you get to, as a graduating resident, level 4. One thought is that if you're doing these during medical school, it's part of an advanced competency, but if you're doing them as a resident, it's a competency. So a way to bridge that gap between medical school and residency. Was there a problem with ultrasound proficiency? So out of the Northeast, they did a survey and they outlined 23 EM milestones and asked various physicians their comfort. And out of 8 of the 9 competencies, most of them felt at level 4 or 5, but for ultrasound, only 44% felt at a level 4 or 5. So practicing physicians may not be comfortable with this competency. How do you get comfortable? Things like having checklists. This is what we call our ultrasound standardized assessment test, looking at the FAST exam and looking at these various domains that we wrote a paper on called the AAMC method, indications, acquisition, interpretation, medical decision making. And so when we're teaching them, we follow that method. Then when we're assessing them, we follow that method of, do they know how to acquire the subxiphoid view, the perihepatic, the parasplenic view? Can they then answer questions as far as interpretation questions, medical decision making? And then they're getting scored on this. And so a way for them to take this USAT as part of the various curricula and then demonstrate that skill set. You combine this framework with eager students, facilities with a simulation lab, student champions that can scan, self-scanning modules where they can go and practice, leadership opportunities where they can lecture and teach others, and then you have a framework that then you can ask questions such as, can medical students achieve competency in MSK ultrasound? When my colleagues in physiatry took this framework for milestones, they did not have any physiatry ultrasound milestones, and took the same framework that emergency medicine had, but then adapted it to physiatry and looked at, can you apply these assessment tools to various participants? She compared medical students with PM&R residents, had knowledge tools such as iBooks with material and content, checklists that we just showed you that were focused on musculoskeletal, and looked at the comparisons. And the medical students had rated themselves at a higher level than the residents as far as basic skills, and that proved out. And what she developed is this framework for milestones that I think could be applicable to all the various specialties as they're trying to define what is the skill set that they need at residency and attending level, but could you make it as part of an advanced competency early on in medical school? So really delineating that learning curve. And so looking about how many hours ultrasound training you have, the foundational examination. She was talking about some milestones before getting up to a level 1 of any core neuromuscular ultrasound SIM scans that they perform. And then going down this algorithm, she used the FinOff's curricula on MSK and AIUM, our IAM technique, and then emergency medicine milestones, a framework. And I think that this can be used in other areas. And coming down to the fact that if medical students can complete these during medical school, it's considered an advanced competency, and then they can go into residency. And not that they can opt out of different requirements, but they can start at a higher level on day one of residency, and thus maybe do more advanced things during the residency. So the milestone is a concept to be able to be a bridge between UME and GME. And ultimately, if we can coordinate ourselves, it could possibly be with MOC as far as the maintenance certification. So at Ohio State, we had an old curricula that had components that all students could participate in at the outer circle that were mandatory. Then there were elective components in the inner circle, and they all had different time allotments. We transitioned to a new curricula where anatomy now was over a 2-year period of time, over 7 blocks of areas. The Med 3 was a series of 3 rings, getting them prepared for rotations. And then the 4th year was a concept of an advanced competency. So we took our old curricula and adapted it to this new one and came up with what we call an advanced competency in ultrasound, a general advanced competency. And what this really showed is how we train our fellows. It's not only clinically being able to do ultrasound, but also all the other components. Can they develop educational programs? Can they know the current research? Can they participate in administrative aspects? So if you look at the clinical, it's basically some of the same framework that we just showed you as far as emergency medicine, knowing the indications, being able to do it in simulation, doing it in the clinic, getting a certain number of exams, and then saving and documenting those. But for administrative, we have an ultrasound interest group. If you're a member, you get some credit for being a member. If you're on a committee, or if you chair a committee, or you lead a program, then you're getting higher levels of this advanced competency in basic ultrasound. Reviewing the literature, we have journal clubs, presenting an article at a journal club, developing a project, presenting at a national conference, and publishing a manuscript. These are milestones that students can do as far as related to ultrasound, showing their prowess. And then the education, being able to participate in proctoring others. So this is how we use this framework to look at advanced competencies in a 4-year curricula. And so what our core competency is, and we delineated this a long time ago, was just vascular access in a simulated session. So all medical students can graduate with that proficiency, starting with a small bar and saying it's very useful for all physicians. But then those students that are participating in elective and want to get that advanced competency as part of LSI Part 3, they can start at any time during their 4 years. And depending on how many of those sub-competencies they complete, they can go to the various levels, level 2, 3, 4, 5. If they do everything and are presenting at national meetings, they're leaders, then they can get that level 5 advanced competency. And it's basically the different programs that we have, it's all hours-based. There's major programs that we have that can give you a level 2, but then you start mixing these major with some of these minor programs that show participation, and then you get up to these various levels. And so what I think that this is all doing is really defining what I think is a new field. When they say ultrasonography, that's really the acquisition of images, but that's not what we're talking about. We're talking about acquiring images, we're talking about interpreting images, we're talking about making decisions at the bedside and using this as a tool. So when we're talking about this, I think it's really delineating that process for those stem cell medical students at Med 1 that are going to turn into every type of physician in Med 3 and 4. They're going to start to delineate, and then when they go into residency, do they have milestones for ultrasound? And so far, I think there's only one specialty that has that yet, and I think there's a need for others. And then after they finish residency, how does the maintenance of certification program continue so that they can make sure that they are continuing that skill set? And so I think that this really needs to be delineated, and this transcends the various specialties, because we're all trying to do this together and figure this out. So it's really, doing this at the bedside, clinical service, education, and research. So part of the AIUM, we had a meeting for ultrasound in the future, and just thinking what the vision in 2020 would be. That's 5 years from now. And so where is the standard education with ultrasound? So do we have ultrasound milestones and requirements in medical school and residency? Do we have that early integration into all the medical schools that are training? As our previous speakers talked about, we're getting more penetrance, about 40 to 50%. Can we get the researchers, the basic scientists, with the clinicians and the sonographers and sonologists, trying to get those people that are in the traditional curriculas, trying to see how ultrasound can help them, whether it's in anatomy or the basic scientists, and mixing with the clinicians in Med 3 and 4 that are teaching our students. And so I think one of our challenges is then at the UME level does the LCME, right, currently they do not check for any kind of ultrasound proficiency, but could that be in the future? At the GME level, at the ACGME, again with the milestones, I think that's going to be where the ultrasound can be used as a measurable task. And so, as I said, emergency medicine has, I think that this is a framework that could be applied in other specialties. But I don't think that the codification has met that. And then finally, everybody is trying to toy with this maintenance of certification of our operators. And so I think that the milestone concept could be adapted toward those attendings. But a lot of them that are practicing never had these when they trained. So hopefully by 2020, we can get some coordination, some consensus, and a streamlined process that makes sense to all. So it's very clear that medical students can be trained to be able to use this ultrasound tool, and milestones are stages in development to this proficiency skill set. When you're measuring assessment and trustable professional activities, they're going to be more widespread at the GME level, and I think that they can be used as a bridge toward getting medical students that are doing things in medical school that could be considered an advanced competency if they're ahead of the game. Eventually, I'd hope there would be a basic competency. But milestones are able to track the concepts from Miller's Pyramid of knowing, knowledge, showing, and doing. So I think that our main challenge as a group and as educators is really developing that standardized system to assess milestones, their impact on patient care, and how we are going to train the future of ultrasound trained personnel in the future. Thank you, and if there's any questions, I'd be happy to take those.
Instructors do you have who evaluate, say, at a medical school of 150 students, and how do you assess that they have the proficiency to identify an artery versus a vein?
So at our institution, this was the bottom-up approach. I wish that I could say it was the top-down, and I would say that if you had a choice, the Dick Hoffman method of getting millions of dollars in equipment and telling all the chairs to implement this is the best way to do it. But if you don't have that, so I started and I had a passion. I saw that, and so I've developed, and it's really been through emergency medicine or some of the leaders, and so a lot of our faculty are part of the ultrasound faculty in the medical school. And then I've developed a series of programs where then there's a lot of senior students that are pretty savvy, and then slowly got in other faculty from other disciplines, but again, they're trying to catch up on trying to learn point-of-care ultrasound. But what we have done is that we have resources, materials, and then are slowly, continually getting into various portions of the curriculum because we've, through longevity, have the lab, have the equipment, have the student interest. So the answer is it's going to be faculty, usually from emergency medicine and/or student peer leaders through different portions of the curricula. So in anatomy, for example, during head and neck, we are actually training some of the anatomists also to fill some of those roles. But again, it's a slow process, but it's faculty usually from the clinical faculty, and then slowly some other faculty that are doing those measurements. Yes, ma'am.
So I may have missed this at the beginning, but what's the status now for the reception from the LCME and the AAMC for incorporating milestones for ultrasound into national accreditation standards?
I don't know that it's on their radar. we just went through an LCME visit, and I don't think it's on their radar. Now, what different programs are doing are trying to take what is on their radar and trying to adapt it to how it relates to ultrasound when they're talking about hands-on learning and, using technology. But there's no specific, that's what I said, there's no specific LCME requirement. Jeanette, did you have a?
Yeah, no, I was going to comment. I don't think it's on their radar. My specific question actually had to do with that, which is, would incorporating ultrasound more into improving clinical skills proficiency be a better route to get there? Because I loved your presentation on competencies and outcomes, because that's a really hard concept, and you've moved it really far down the rail. But my question is, why do you feel that we should call it sonology? Why should we just not call it clinical skills? These are our clinical skills of the future. This is what we need to do, and ultrasound is one way to learn anatomy and physiology that we didn't have before. I mean, we used to have it, right? We'd have a radiologist drop by and show some interesting pictures, and we'd see some CT scans, right? But now we are more actively involved. So that was my actual question to you. I don't think it's going to, look at how long it's taken to get interprofessional education, and we still don't know what that is. So I think that we are a long ways away, and hopefully going to tackle it from the GME issue. But also, my question to you is, do you believe that we need to call it something different?
I think that's a great question. As far as the LCME, I think that it should be on their radar, and maybe in the future it will become on their radar and then put into the. Once that does, I think you'll see a wide adoption that people start getting on board. And it's the same thing at the ACGME level, where if people are told that this is what they're going to be checked upon, and they then will change some of their behaviors. The challenge, Jeanette, is that there has been this has grown at each specialty at its own pace, and so there has not been a coordination, and so there is a lot of ambiguity as far as where the direction of this is going. And my perception being I'm a member of 14 organizations, all the ultrasound organizations, all the emergency medicine one, and you go to these different conferences and you hear different takes on some of the same concepts, but they're different, they're looking at a different prism. And when you look at the history of ultrasound, there's always been, it's usually in the radiology community, that a sonologist was somebody that was able to scan and interpret. But you go into Merriam-Webster and you type up sonologist, or you type in ultrasonology, and there's no terms for this. Where this came about was that when some of the emergency medicine groups are trying to petition the AAMC toward developing a sub-board for this, and they said it needs to be a unique body of knowledge. And so I was talking with Dr. Tayal about this up in Chicago a few years back, and really the need is that there needs to be a brand. And I think that that's when it just hit to me that there's a difference between sonography and sonographers acquire images, but they don't do any interpretation. And as we developed that IA method, it seemed like it's a real field. And so we're looking at the back end of what are we trying to do with these clinical skills and teach them in medical school, make sure that they're able to practice those in residency, and then when they're finally complete and trained and then use this, it's really it's a separate skill set that is combination of acquiring and interpreting, and then using that data contemporaneously at the bedside. So it's just a thought, and I just trying to think is how do you bring consensus to all this disparity with the 24 different medical specialties all trying to do this same thing, and there's not a coordination. So that's just some rationale behind it. Yes, ma'am.
It's just a further comment on the same thing. It just seems like there needs to be a coordinated group to come up with a lobbying, brainstorming group to come up with an argument why we should be made into competencies based on outcomes and based on evidence. Because the indices are already there. Improved patient care, improved communication. It already dovetails in with established competencies that the ACME and the ACGME and LCME are already behind. And Eric Topol was a presenter at one of the AAMC conferences. He's already pretty much sold it. So.
I agree with you wholeheartedly, and I just think that it seems so obvious, but I think in medical education, I'm just puzzled on how hemochromatosis gets the same amount of time as diabetes, and things like that, and ultrasound. Some people may think it's esoteric, but every day that you practice, and that first slide one of those first slides talking about all the different specialties and all the ways that they're using it, and guess what's happening? People are finding new ways to use this because it's a tool. So it makes so much sense to me, but I agree with you, and I think that's what's needed. But it's the next challenge is really those political groups and trying to get them coordinated and saying, what's the goal that we want on the back end for physicians, and how can we use some of these different groups at the various levels? And that's why I try to show some of those literature of people trying to do that, of say the ABMS and all that data that they're collecting on their physicians. Can that be the milestone or outcomes for the ACGME? And can the ACGME have some milestones that are translated back to the UME level for the AAMC? Jen?
So I was gonna make the opposite argument, which is that I think that, after having been on the ACGME, trying to get simulation into institutional requirements after being on the ABMS and understanding what it takes for a new field, people argue that this is a technology. It doesn't change who we are. And so it is not a separate field. That's the usual argument we get. So I was going to make the argument that the best place to get into LCME would be through the educational module. Something like a requirement that says, and your basic sciences should be taught in conjunction with multimedia, ultrasonography, et cetera, et cetera. That seems like an easier lift than the other approach, which is why I was asking the question.
I don't care what approach works, but just get it to the bottom line as get the clinicians, because everybody in this room, I think, is all on board with that. But I think that the need is there. I just think that there's a real disparate, and I think it's a cacophony within the house of medicine, and we need to come and speak with a more singular voice, whatever it is. Thank you so much. Oh, wait.
I just have a single comment
Yes.
about saying, I think we need to have more other specialties as well involved in trying to get this more traction as well. I'm a radiologist, and I understand a lot of people in this room are emergency medicine people, and I think other specialties, like, I'm talking about liver, hepatology, gastroenterology. I think if we get more specialties on board, the traction of trying to get this further is going to be much, much higher. And so, yeah.
I wholeheartedly agree with that, and I think that what has happened is that this, as emergency physicians have found, this point-of-care ultrasound has worked as far as the clinician-performed ultrasound. They have been the ones trying to train, but we're working at the AIUM. We have some radiologists in some of our working groups, but you're right, it needs to be all the specialties involved trying to coordinate what's the best practice in the future. Thank you so much for your attention today. I really appreciate it.